Hi everyone, welcome. We're going to go ahead and get started. Just while people are still coming in, I'm going to go over a few housekeeping items. Please make sure to mute your line. We will have time for questions and answers at the end. If you have a question during the presentation, please type it in the chat box on the right-hand side of your screen. Please close any other applications or windows that you're not using to conserve bandwidth. And then this webinar will be recorded and uploaded to our website next week. And I'll send out an email to everyone that registered, and it will be posted on our Twitter page and on our website. So with that, I'm excited to get our presentation started. I'm excited to have Jen Brown and Candace Henley here to join us and present, and I will pass it over to them now.
Thanks so much, Claire, and really glad to be here with Candace, and we'll just jump right in. And Candace already covered this information, or Claire already covered this information. Good afternoon, everyone. My name is Jen Brown, and I'm the director and co-founder of the Alliance for Research in Chicagoland Communities, and I'm honored to be here with Candace.
Hi, everyone. And it's such an honor for me to be here as well with Jen presenting on such a very important topic of healthcare equity in healthcare.
And we put our Twitter handles here too, in case people want to include us in the conversation online. We just wanted to let you know that we're both representatives of ARC. And here's the focus of our organization, which is catalyzing and supporting engaged community academic research partnerships to improve health and equity. And there's our website. We also want to acknowledge that ARC works to practice community engagement in our own governance, and everything ARC does is guided by our stakeholders on our steering committee, which always includes more community than academic representatives. You can see our members here, and Candace is our current community chair. Before we get going, especially during a session focused on equity and engagement, we want to pause and acknowledge that this is a very challenging time in the world, and especially in the US and Chicagoland. We are in the midst of a global pandemic, and we are in the midst of civic uprisings against structural racism and police brutality. I want to acknowledge that this is certainly more difficult for some than others, including those who are immunocompromised or living with a disability, or Black or brown or other people of color. So before getting started, we want to lead everyone in taking a deep breath and letting it out. Today, we're focused on health equity. This is a definition from Kamara Jones, a former president of the American Public Health Association. And we will be raising more questions about equity, things for you to consider, than providing prescriptive information or recommendations. We're hoping, Candace and I are hoping, that we'll give you things to reflect on individually and collaboratively with your academic and community partners, your clinical care partners, your students, your residents. Healthcare and services and health research have not historically, and many times presently, have not been developed with a focus on equity. So we need to be willing to critically reflect on and examine the way we do things, including the quote unquote things that we've always done. We know that without explicitly focusing on equity, we will widen gaps and disparities. And examining things like this may be uncomfortable. We want to acknowledge that, but as one of our partners said, we cannot prioritize comfort over equity. So during today, Candace and I will be talking back and forth during this conversation, and we hope this exchange, this kind of bouncing off of each other, will be valuable. And we also look forward to including your voices and perspectives as well. Feel free to use the chat as a conversation between and among yourselves and each other, as well as asking questions that we can respond to. So throughout, in a virtual environment, it's, we can't see you and get your feedback. And Candace and I can't touch base in the same way, but I'll be, pausing and asking Candace if she wants to add to, and she'll be doing the same with me. So before I go to the next slide, I'm going to invite Candace to add anything before we move on.
Hi, expounding on what you've already mentioned, we are in a time where in the last few weeks, we've seen images that have been disturbing, and in the last few days, images that have been disturbing. And so, and I just want to say that if it disturbed you, if healthcare inequity upsets you, if it disturbs you, good. You should not feel comfortable having this discussion, because it's not comfortable, and it has not been comfortable for the communities that have experienced healthcare inequities and that have experienced racism. So this is designed to make you feel uncomfortable so that we can have the discussion and advance the mission forward to how do we make change? How do we exact change in the structures in which we are all involved in? So I'll leave it at that.
Thanks, Candace. So when we talk about using an equity lens in healthcare and in research, for whatever issue we're focusing on, have we thought about what the root causes are? Have we done a root cause analysis to understand the full structural inequities related to that issue? It's important to think about the ways that we often focus on individuals or individual health issues acontextually without understanding history and social structural forces or policies or systems that are impacting those issues or those individuals. So for any issue or individual or intervention in the status quo, or what the kind of impact you plan to have or hope to have you examined who does or who will bear the burden? Who does or would be advantaged by what you're currently doing or what you might be doing? So how is our clinical care? How is our scholarship, both in the research participation or in designing a research or other intervention, taking into account the type and addressing the type of historical injustices that Dr. Jones referred to in her health equity definition? And how is our care or scholarship providing resources according to need that facilitates engagement and impact, and not just using a one-size-fits-all approach? So we might need to consider our role in what one of my colleagues calls the health disparities industrial complex. How we need to reflect on, get uncomfortable, as Candace said, and reflect on how are we actually benefiting from health disparities? How are we getting more grants and more publications and more institutional funding? And how are we potentially just continuing to describe disparities rather than uncovering or addressing their roots? Often our interventions are still at the individual or community level rather at looking at system or structural level. A lot of times when we talk about equity and in the way we've talked about it so far, we talked about it generally, but also need to consider for health equity work, are you specifically and explicitly having a racial equity lens? And what is the role of having a racial equity lens versus talking about equity more broadly? Candace, anything?
Yes, actually, and it's interesting, to have this discussion about this, because I recently saw on Twitter a photo that said "White Coats for Black Lives Matter," and as moving as I thought it was, they were all in a kneeling position. I couldn't help but wonder exactly what does that mean, because you're in an institution, you work in an institution. So how does White Coats for Black Lives lead to change? It's one thing to kneel and to show the images. It's another thing to put it into action. Does that mean that you're going to challenge your institution the way that they do business as usual? Are you going to challenge their contribution to healthcare inequities? Are you going to join us on Capitol Hill when we are taking our plights to our lawmakers? What exactly does White Coats for Black Lives Matter mean? Does that mean that when we come into the emergency room, you're not going to see us as Black lives, but you're going to see us as human beings? You're going to see our humanity. Are you going to champion your colleagues to see the humanity in Black lives and not just treat us and then send us on our way? What does white coats for Black Lives Matter actually mean? And that is something that, again, it was great to see, but it prompted more questions for me. It prompted more questions as to how does that relate to healthcare equity? How will you take your position and help change the inequities in healthcare? So, yeah.
Thank you, Candace. So I think, Candace is bringing up, asking us as those with power and privilege to think about that power and privilege and how we're going to wield that. So when we think about our focus on equity, when we think about the questions that I was posing on the previous slide, who's asking these questions? Who's making the decisions about the answers to these questions? And what does it mean when we have conversations about equity to develop programs and interventions and advocacy to address inequities without those most experiencing inequities at the table and in the lead? So really, again, asking us to reflect on, what happens when often it feels like research or interventions are used to tell people stories for them or to tell them what they should or shouldn't do. And how can we shift our frame to be thinking about how research can be a tool for communities to tell their own stories, not for those that are not representing them to do that. And that's, why today's conversation really about the intersection between equity and community engagement is so important, because part of the reason that this is true is that communities experiencing inequities are so underrepresented right now in our health and research institutions, especially in decision-making positions. So we must constantly think about what are the ways that we are centering and elevating voices of people most experiencing inequities. We as providers, as researchers, as representatives of these institutions can think about how we leverage our power to make space for and then support community leadership in these spaces, because it's not enough to give community members an equal opportunity to engage. We need to intentionally and actively meet communities where they are and not making engaging an additional burden for them, but provide opportunities to engage that meets their unique needs, whether this means providing fiscal support, doing things in the evenings, or providing transportation and childcare, and also intentionally thinking about how we support the development of community leaders who are leaders in their own realms to also be leaders in our institutional spaces, academic, health institutions, and the not. Candace, let me invite you in here.
Absolutely, and community engagement is not coming into communities of color and saying, you need to do this, 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 and this. And because statistics are showing this, you need to do this, this, and this. Well, we all know that statistics, they're almost like they're like weight and measures. So it depends. Do we know what the problem was? What that community was facing, what the challenges, that each individual, because it is not one size fit all. So because my neighbor to the left has diabetes and my neighbor to the right has diabetes, doesn't mean that they are wired at having diabetes at the same cost. And so when you're looking at social determinants of health and you're looking at statistics and data, you also need to step outside and you need to look at the other factors that relates to this, and those are the barriers. Those are, what are the cultural barriers? What are the religious barriers? What are the taboos of each community? Because we have to understand, in order to do community engagement, we must understand each and every community individually. We need to know, what is considered taboo and acceptable to talk about in the Asian community, as well as what's acceptable and not acceptable to talk about and the Black community and the the Latinx community. There are so many components to it, but if we're not doing it correctly, if it is not being done in the lens of understanding first, not just saying this is what data says. Okay, that's great. That's what data says. But what does the community say? Have you listened? And it's very important to listen, because for years, no one listens. And it's like, okay, this is the prescription. So we're writing a prescription for your community without knowing what the community needs. We need fresh fruit and vegetables. We need access. So before you can start determining what the best needs of these communities are and saying, well, this is what it says, you need to go in that community and you need to speak to, to members of the community, and not just one or two, and not just leaders, but speak to the community itself. Come, engage, and then learn, take back what you heard and learn from it, and then see if that changes your point of view. It should change your point of view. And if it doesn't, then do a self-check, do a pulse check, because now you're tone deaf. So that's my addition to this so far. I don't want to get ahead of the slides.
After every speech, I just want to say, preach, truth teller. So this is really starting to get at some of what Candace was bringing up around, so when we talk about community engagement, what are we talking about? Who is the community, or who are the communities? Who represents the community? Who has that mantle? What do we mean by this? And usually ARC considers this in two ways: those who are impacted most directly by the issue or the topic at hand, as well as stakeholders who have the power to make change based on an intervention or based on research findings. So all of these types of entities that are listed here in what we call the stakeholder flower may be relevant to what you're doing. If we were in person and had time for engaging, I might give you a blank copy of this and ask you specifically related to what you do, what you're hoping to do, what you're trying to achieve equity in, what are the relevant stakeholders or communities related to that. And Candace brought up a really good point that we're often engaging with community representatives in their professional roles at community-based organizations, patient advocacy organizations, public agencies, schools. But we also need to engage individuals with lived experience, community residents, patients themselves, caregivers, youth, which may have different perspectives and different types of lived experience than those who are doing this as a part of their job. The other thing that's very important to consider is, are we getting at who's most experiencing inequities? So for example, if we're addressing health equity within the LGBTQ community, white cisgender men have fewer inequities than Black trans women. And so how are we keeping that in mind as we do engagement and as we design things related to improving equity? Same for older adults. An older adult with economic resources and who speaks English will have different access to resources and different types of equity issues than someone who doesn't. So when we talk about community engagement, it's important to recognize that this is really a long-term process with community members as partners in identifying action steps. It's an intentional practice that, as we talked about on the previous slide, includes diverse perspectives of communities and addresses power dynamics. And this really requires us to continually examine who has historically or currently been left out of decision-making processes, and how can this be shifted? Focusing on long-term trusting relationships. So these relationships are the foundation for everything and cannot be rushed to develop authentically. This is about working with community, not doing things for community or just in community. And it's important often for us to reflect on, the potential for savior syndrome, or, feeling that we can provide what folks need, when often as researchers, as healthcare providers, we have as much to learn from community as they may have to learn from us, as Candace shared earlier. And then, of course, leading to action. So this is not a one-time thing. This is far more involved than community outreach that might share information with community members or be short-term in getting input. This is about a long-term, continual process. Candace, I invite you to come in here.
Yeah. So and be. I think when I was getting involved in trying to do more with institutions, I was met with a lot of resistance. And here I'm a patient representative, but I'm also a community member, and I'm sharing with you not only the community aspect, but I'm also giving shared experience from my own personal experience, about my journey. And my voice is powerful because I choose to speak on my experience. There are some people in the community, they haven't found their voice yet, or they question, because I questioned whether or not what happened to me was a healthcare inequity. And when, and I had to look at it through a different lens because I lived it. But then once I stepped out of it, I looked at the different angles and saw that I had actually lived inequities. And talking to other community members and then sharing their voice and sharing their stories and saying, hey, listen, I want to work with you. And I was met with such resistance as if what I had to share, because it wasn't a PhD, it wasn't important. And that was the biggest mistake, because when you fail to acknowledge the voices of the very people that are experiencing from your healthcare system, they are experiencing treatment, they're experiencing, whatever it is from your system, and you don't want to hear it, that leads to tone deafness and business as usual. And so that continues to show your contribution to the inequities as they are today. So we must be willing, you must be willing to listen to community members, but also there's a give and take, because I also realized in order for me to be heard, I had to speak in a language that connected us together. I couldn't come off as being the angry Black woman, because immediately you shut me off. You don't see me. Although I have a right to be angry about the injustices that happen to me, you don't hear me if I come to you that way. But if I share with you and I bring it into a different tone and a different perspective, although I should have the the right and the ability to share my anger, it's dismissed. It's not heard. So I think that we have a shared responsibility to speak in a language with each other that we both find receptive and respectful, so that we can work collaboratively and trusting each other and working to have and foster long-term relationships.
Candace, you raised so many important, deep issues, and I hope we're going to have a lot of time for discussion with everyone on the webinar today to talk more deeply about this. And I think some of the things you raised too is this is so much not about just saying community engagement, but how you approach that and how you do that, which we'll get into a little bit, but the approach that you use, because so often we say we want to establish equitable, from the institutional level, we say we want to establish equitable partnerships, but how equitable can we be if we're inviting community members or community representatives into our space and expecting them to sit at our tables and potentially, be uncomfortable or not uncomfortable sitting around with a number of people that have a lot of letters after their names, or they've had to come into an institution where they may or may not feel comfortable. We may not have driven down to their neighborhood, or which may be in a different place from ours. What is the way that we set the table, or what is the way that we're willing to go to another table and develop a new way of engaging? And so I think you really bring up so much related to the how. So we'll talk a little bit more about the how, but On this side, the principles of engagement on the left-hand side of the slide are the principles of engagement that ARC and the Center for Community Health use related to collaboration, respect, equity, transparency, and impact. So we'll talk a little bit more. We also just shared this because in terms of the approach of community engagement, it's really about honoring that there are multiple types of expertise. Yes, there are expertise that come from being a clinician, an educator, a researcher, but that we're also honoring the expertise of communities in terms of their local cultural lived experience, practice, expertise, and that we have to see as necessary the bi-directional exchange of this expertise if we're going to have research or services that improve health and equity. Let's see, let me go on to the next one here. So what does this look like? What are the ways that community engagement might happen? So part of this slide is related to when we talk about engagement, we're really talking about a spectrum. Sometimes the efforts that we're working on may be driven by communities, and they've reached out to us as researchers or health professionals to be a part of that process. And some of it, sometimes they may initiate at an institutional level and be engaging community stakeholders. So it might be very engaged, kind of starting at the top with leadership or shared leadership that is driven by community or co-driven by community and institutional partners, all the way down to where a lot less engaged and more, informing or observing. And so these are some of the strategies, just examples of types of strategies that people might use. What does community engagement look like? A lot of times folks are using a community steering committee or a community advisory group, which is kind of in the middle, gathering information from community members or getting input through or listening through focus groups or storytelling or town halls, those sorts of things. I think one of the things that's important to consider is you're not going to just look at this slide and say, oh, this is the one for me, I'm choosing that one, that will be it. You will need to think about multiple approaches to really address the types of multiple layers of community that we mentioned. It's not going to just be one, but you'll be using different approaches at different points with different groups. And also community engagement should start as early as possible. Who is designing the community engagement strategies? Who's choosing what that looks like? Is that only you as institutional representatives, health professionals, researchers, or are there a smaller number of community partners that are engaged to collaboratively make decisions about what those broader engagement strategies might be? Candace, would you like to?
I was just going to say, yeah, and I'd like to add to that too. Oftentimes, people are in their professional capacity. And so what I like to say is take off your white coat before you start community engagement, because it levels the playing field, because you have your level of experience and education in what you do. We have our level of education and experience in what we do. And so it is a way of communicating that there is no power here. We're all here together to come together for a common goal, and that is to find out how can we make this change. And so the way to do that is to remove your academia, remove your white coat, and let's have this conversation. One of the best engagement strategies I had experience to witness was one of my doctors in the colorectal cancer community, which I work with. She sat down at the table. She didn't sit in the front of the room. She didn't have her white coat. She sat down at the table and she shared and she had discussions and she spoke to each and every one in the room. And that to me let me know that she got it. She understood. And so sometimes I think just the smallest of gestures that you may not think make a difference, it makes the biggest difference, because we're now leveling the playing field. And it's like the previous slide. Who has the power? We all have power to a certain degree, but this is not the time to poster power, coming in. This is the time to listen. This is the time to understand and to say, okay, you know what, I'm here. Although I'm here in official capacity, I'm here on the capacity of understanding.
I think that's very important, Candace, is that, often underestimate how meaningful small human things like where you sit and how you introduce yourself can be. At ARC, we're sometimes in the role of brokering partnerships between community and institutional partners. And sometimes I'll have to remind people, like, we may have made a match and they'll, be communicating, oh, can you tell them this, or can you ask them to do this? And I'm trying to explain to them that this is part of engagement. We are not playing this role anymore. This is where you reach out and introduce yourself and be a person and thank them for engaging and, start to, go out for coffee and, that kind of thing. I also want to acknowledge, I saw a message in the chat about, how can we help, the question is, how can we help community members better communicate their needs so that we all speak the language, and vice versa for the academic and medical community. This is something we'll probably talk more about in a minute too, but I think part of it is that that we need to shift the frame, is that if we are going to have equitable relationships, equitable engagement, equitable partnerships, we need to think about who already has power and privilege in a situation, and how can we make sure that any burden or any change being asked is of those that have more power and privilege. So it kind of, like, for example, it bothers me when we talk about hard to reach populations. Their communities are exactly who they should be and are being exactly how they should be. They're not hard to reach. As institutional partners, we may be bad at reaching them, but it's for us, we have the power and privilege. It's for us to change and build our own capacity about how we can communicate, how we can engage in a way that fits with where they are and what they need, but not ask them to change to be able to better, communicate that to us. So I think a lot of this comes from what Candace was saying earlier around, what homework we as institutional partners have done to better learn about and understand communities and be able to reach them. Candace, is there anything you would like to add on that point?
Yes, and sometimes and that question actually is, when you say, what do you need? We're so used to not being asked what we need that when you ask that question, it's almost like, well, I don't know, give me a moment to think about it. But while we're thinking about it, tell us what you can do. Because it's I don't know what to ask you if I don't know what you can offer. I don't, and so I think it's give and take. It's, I don't know what you need, but here's what we can do. And then speak back and forth. And then in terms of the language, the same language, it's all the same language. It's listening. And it's communicating to each other that this is what our experiences are. And it's also respecting the experiences of the community. Because just because it's not your experience, it's not fair of you to say, well, I've not experienced that, so I don't understand it. We pretty much get that. Just simply say, I empathize, and I'm here to listen to see how we can best serve. Comparing experiences is actually the wrong way, because a lot of times we try to make commonality by sharing experiences, and sometimes that kind of rub you the wrong way. It's kind of like, so you're trying to compare apples to oranges, and it's not so much that it's we know that it's trying, but sometimes it's like, just listen and not try to share what your experience may have been, but just simply listen and say, well, you know what, I'm sorry that happened to you, and I want to try to make a difference. We as an institution want to try to make a difference. It's acknowledging that the communities have needs, and they may not always know how to communicate that need because it's vast. It's not just a small thing, it's vast. So I'll leave it at that.
Thank you, Candace. And I think that point too, that sometimes communities may need the space to express experiences they've had, negative experiences they've had in the past. And even when an individual or an institution is trying to make change and move forward in a different way, that doesn't mean communities are like, oh, great, oh, go ahead, well, then we forgive everything. Sometimes people need a space to share what not felt good in the past too. Like there was something else I'm going to say about. I'll leave it for that for now. So this is a busy slide, but I partially wanted to include it so that you could have a chance to look at it later. I hope you find it helpful. This is from a colleague of ours in Tennessee, Dr. Consuelo Wilkins, and it's laying out, some of these same community engagement strategies that we had in the previous slide. But on the vertical axis, you see the extent of engagement, whether this is really deep engagement at an ongoing way or something more short-term or one-time involvement. And then on the horizontal axis is the number of stakeholders or the number of people that might be involved. So again, it's helpful to think about, it's not going to be about choosing just one, but which type of engagement is appropriate for the type of feedback or the type of collaboration that you're looking to have. So you may at some point in your work be wanting to gather feedback from a lot of people through listening sessions and surveys and focus groups. But there's other times where it may be helpful to have a smaller set of community partners that are collaborating more deeply on an ongoing way, that are really involved in all aspects of decision making and have an understanding of what the project is doing at a deeper level, that can be working on different issues. So again, thinking about what's the right fit, and that there's not a one size fits all for each type of stakeholder or type of community. And so then as you're doing this, really thinking about how are you pulling that equity lens through your decision making around engagement strategies and choices. So who's engaged, who's making decisions? You might be engaging people through listening sessions, but that doesn't make them a decision making partner. Who will be advantaged by the type of engagement strategies that you're using, and who will be burdened by the type of engagement strategies that you're using? Okay, this is an important slide, and I'm going to stay here for a minute. So doing this work really asks people to do some reflection before they start community engagement and during, while they're engaging communities. So the first point is one that Candace talked about really well. What do you know about the communities that you're going to be working with or that you're going to try to engage before you engage? As health professionals or researchers, we would never begin something without doing a lit review, but we often begin working with a community without taking the time to learn about that community. So all of the things that she mentioned, the history, the power relationship, the assets, the good local restaurants and businesses, how have you developed that? Part of this is also, have you reflected on why communities would or wouldn't want to engage with you? What are their perceptions of healthcare providers or researchers or your institutions? They likely, as Candace was talking about, have distrust. Do you know the history of your profession, of your discipline, of your institution in the communities or populations that you're working with? If you haven't read Medical Apartheid by Harriet Washington and are working with Black communities, I highly recommend that. Communities may have previously experienced helicopter engagement, helicopter research, where folks came in, got what they needed, and left. They may be concerned about sustainability. Community partners, potential partners may want to know, have you thought about how this work would benefit their community, why they would want to be involved, what it will bring to them, and how new money or resources or interventions would be sustained to their organization or their community. Another important piece of of this is, and also doing this work yourself and not putting that burden of having community members talk about, be the ones that have to educate you. There's ways of you doing this work yourself too. And then thinking about what do you know about yourself? So have you reflected on your own identities, your own privileges, your own biases, and why you want to engage? Doing this kind of self-reflection is important. And also being honest with yourself about how and how much you want to engage. Are you ready to share power? You may have done lots of projects where you were working in a more hierarchical setting, or you were the PI and you got the last say in the decision. Are you ready to truly to share decision making? Do you have the resources or understand the resources that it takes to engage? Have you set aside or have access to funding that will pay community members or community representatives for their time, for their expertise? Have you made time and space for the engagement, which does, relationship building, which can take time? Have you invested in the capacity, have resources for investing in the capacity of those that you're engaging, but also yourself? You likely have not had training specifically to this work. It's often thought of as kind of a soft science or a soft skill, but there is an art to it and a science to it. Do you have mentors for this work, community mentors, academic partners? Another thing that it's important to think about is you engaging as an individual versus you engaging as a representative of your institution, or your institution engaging with communities. Communities will likely have had previous interactions or relationships with your institution or with your discipline before. You might be able to build on those existing relationships, but you also may pay for your colleagues' errors. So you may be trying to take an engaged, equitable approach, but others may not be. And really taking the time to think, before and during about the challenges to doing this work, the time that it takes, and the fact that many of the systems that we work within currently are not set up to support equitable partnerships and relationships. So how can we truly develop equitable partnerships when our institutions typically control all the money and take more than 40% off the top for indirects? And thinking about the impact that will have as you're reaching out and sharing what you say you want to do. And then, of course, recognizing that community engagement is not something that ever stops. It's not something you do at the beginning and then you're like, okay, done, community relationships built. But you will be continually investing in sustaining and deepening these relationships. So thinking about how will you be engaging if your community engagement is successful, if you, lived up to some of these principles. That should not be judged by you. That should be judged by the communities you are engaging. You are accountable to them. So what processes have you set up to be able to have frank conversations about that? And that was something I wanted to say earlier related to something Candace said, was that, when we're talking with people about doing this work, a lot of times they might say like, well, how did another partnership do this? Or do you have a template for that? And really it's the process of having these difficult conversations with yourself and with your partners that is a key piece, not just what you get to. Sorry, Candace.
Oh, no, it's okay. Because I was like, this is really the question that I had to everyone on is, how do you create health equity in a system that was not designed for us in the first place? And that is the struggle. We're dealing with an historical struggle that was not designed for people of color. We were research subjects. That was the advancement of medicine for others. It was not for us. And so the question becomes, how do you that are involved in working in these institutions, how can you change the way your institution does healthcare? Because if you're asking me, I'll say dismantle it all and start from the very beginning. Let's build it up and let's make sure that we're having the faces that represent the communities in which we're serving. We can no longer continue business as usual and not seeing the humanity in people. It doesn't matter whether they're rich or poor, whether or not they're on welfare, they have Medicare, they have Medicaid, they have private insurance. What does it matter? We're looking at people based upon their value. We're all humans. We all have value. And that is what has not changed, is the historical value of Black and brown people. That needs to change. So if you want to know how to do this work, add value to the people you serve. If it were these are parents, these are loved ones. We are people that have children and grandchildren, and we're not animals. We're not what the Constitution says we are. We're not what historically they said that we evolved from whatever. There is humanity that's missing in healthcare when you fail to see people as human beings and you start seeing them as a financial, what their ability to pay or their ability or whether or not they smoke. It's still free will in this country. Who doesn't have a vice that is creating to the demise of their own healthcare? But who are we to judge that? But we have a job to do. The job is we treat people as people. And that is that's the bottom line. And when we're not doing that, when the systems are not doing that, it's failing. And it has been failing, Black and brown people, since we got our freedom. And so, it sounds like it was so yesteryear when we got our freedom, but it really wasn't. And when we're still experiencing the same thing our ancestors experienced in 2020, in the 21st century, something is wrong. And so we have to check our pulses. And then we have to check the pulses of the institutions and those that are head of the institutions. Because if those that are at the head of the institutions are comfortable with the way your institution looks in the eyes of the community, then that person needs to be removed. Because you cannot do your job effectively. You cannot do research effectively if the heads of your institution are not saying you need to have more people of color. And they're not demanding that you have more people of color. They're not holding up funding because you don't have enough people of color. When research doesn't have enough people of color at the very beginning to do community engagement, to talk about and acknowledge historical fears and acknowledge the historical atrocities that have happened in Black and brown communities, we don't have enough of that. These are conversations that we need to have in order for communities to feel comfortable, to feel heard, and to feel valued. Those are the important conversations that we need to have.
Thank you, Candace. I think one of the things that you're raising is that research professionals, health professionals that are doing this work, we have to do two things. We have to understand how the system is broken in the way that Candace is describing and develop community engagement mechanisms and approaches that work within the system that it is now. And it is also our responsibility, again, to use that power and privilege to advocate and work with inside our institutions to ensure that they don't stay broken in that way. But we will, in the meanwhile, we will have to do both. And there's a question in the chat about how do you suggest engaging with a community that has had negative experiences with research institutions already? And this is a great question because we have to, I always suggest transparency and honesty and acknowledging the truth. The truth is that inequities were not, and as Candace said, disrespect and maltreatment is not something that's just in the past. It's something that happens now. And if we can't just go in saying we're going to do it differently, we have to acknowledge how research has been historically and how research is often conducted now, or healthcare has been historically or is often conducted now in a way that perpetuates inequity, a way that perpetuates racism. And we may need to give space for people to express how that feels, and being willing to have that conversation, being willing to be truthful about the ways that we understand our systems, our institutions, and our own actions have not been equitable, and how we have not been doing enough is an important but not sufficient first step. Candace, I want to make sure you can.
Yeah, and I just wanted to add to that too. I think there needs to be a curriculum for research, and that is knowing the history of America and medicine. Medical Apartheid is a book that will anger you, but it's also a book that will educate you. And I think a lot of times we have, there's, people, they hone on Henrietta Lacks and the Tuskegee experiment as if that's the only atrocity that has happened. And it's kind of angering, because it's kind of like, do you not know what else happened? And I think when that's always a primary focus of your understanding of, we understand what you have experienced because of the Tuskegee experiment. No, you don't. Because that's the PG version of American history as it relates to, healthcare and African Americans. That's the PG version. So I think there needs to be a curriculum for researchers before they are engaging in research with communities of color to understand the history of medicine and how it has not been kind, how it has mistreated people of color. So that now you have empathy because you've learned it, because you've listened, not because you watched it on a movie, but or you read a white paper, but because you actually had to study it and you actually had to learn it. And I think that's the best way to understand by reading it. And again, it's like I said before, if it outrages you, good, you should be outraged. Everyone should feel outraged by the fact that we still have healthcare inequity today. And so when we're not educating and when we're not trying and when we focus on just Henrietta Lacks and Tuskegee, that's disrespectful. And I'm speaking as a Black woman, that's disrespectful because more happened than that. And I think and that's how you acknowledge, and that's how you start to gain trust. I mean, it's not an immediate trust, but you start to gain trust because now you are engaged in the actual process of trying to understand why communities of color don't want you to come in or are fearful of what you're saying and what you're, are fearful of being guinea pigs. So this should be a required curriculum.
Thank you, Candace. I agree wholeheartedly. We've talked about some of what's on this slide already. The bolded words are some of the principles of engagement that we showed earlier. And as we think about community engagement strategies, as we do this, like how do those show up? How do these principles show up in the work that we do? How do we create these trusting, long-term, equitable relationships? And related to the point that we were making earlier, really, oftentimes when we're as health and research professionals are engaging, we're still in our using our frame of, we're trying to build trust. We're trying to get communities to trust us. And again, we need to shift our frame because this puts the onus for change and the burden for change on the community, whereas the burden should really be on us as health providers and researchers. So it's not what are we doing to get communities to trust us, but it's what are we doing to be trustworthy? What are we doing to be worthy of their trust, to be worthy of their respect? And recognizing that it really looks different to build trust, to build relationships with individual people versus with organizations where you might be doing this at multiple levels, frontline workers to executive directors, to more abstract institutions or entities what does it mean to build trust in research or trust in flu shots or something like that addresses many of these things. I'm getting the reminder from Claire that we're heading toward the end. I want to open this up to Candace, and then we'll share some resources before trying to get to more questions in the chat.
I would just simply say that we have to trust each other, and that medicine is more than color. And it's the human aspect of looking at another human being and not wanting them to suffer. And it is challenging the medical community to fight for change, not to just be comfortable, not to. And I understand that there can be a lot at stake for those that step up against, the system. But then there's a lot at stake not to step up. There's more at stake. What you're seeing today, what you're seeing happening in the last couple of weeks, this is what happens when you don't step up. And so we can't continue not to step up and not to hear. We have to, and we have to do it with each other. We have to work together as a community engager and as an advocate and as a patient. I want to work so that I can help cross the divide on both sides. And that takes us doing this together.
Thank you, Candace. As we are getting close to the time, I'm going to share some slides that have some resources. Candace and I are both based in Chicago, so these are some Chicago-specific resources for those of us who are also here. I know you'll have these slides, so I'm going to go through them quickly. These are some resources on the national level of folks that are, or organizations that are focused in community engagement or equity or both. And again, and we're going to give you our contact information. So if you can't find these or you want more specific information about any of these, let me know. I did mention Kamara Jones is the one who gave us our health equity definition within the American Public Health Association. They're starting a 4-part series on racism, and on June 9th, Kamara Jones is doing the first one of those, so keep your eye out for that. At ARC, we also have some resources. This is the web link to our resource directory, which has a lot of things related to community engagement that could be helpful. We also put out this monthly list. June 16th, we're continuing a set of virtual conversations we've been having about what it looks like to do community engaged research during COVID-19, and we're going to be exploring now also how we do it during, 2 health crises related to, structural racism and police brutality and COVID-19. And we also have been doing a virtual evaluation training series, so just wanted to let folks know about that. And here's our contact information if you want to get a hold of us. There was another question in the chat. Thank you for the conversation in the chat about how do we get Black and Brown communities to unite and to understand that we are fighting the same battle. Are there coalitions out there for both to come to the table? And I definitely want Candace to speak about this. I think that locally and more broadly, there are tables for folks to come at, and we can try to share some resources for Claire to send out about that to the folks that registered. I think, continuing on what Candace was just saying about the need for literally coming to the table and talking about things together is a key part of this. Candace, do you want to join in on this?
Yeah, we communities of color, we're all broken, and we're all experiencing, the same heartbreak. And I think it comes from that very thing, is seeing each other as we are fighting the same fight. And and in order for change to happen, there has to be that collective action, but it takes time. There is, unfortunately, the damage is so long and it is so vast And it's so hard sometimes to move out of your own vision. But I think with continued voices, such as mine and others that are on the call, on the webinar, and Jen, and institutions, such as ARC, and I think having this continued conversation, and right now, with everything, this is the right time to have this conversation. So I think continuing to have this conversation, but having them with everyone, not just Black and brown, but let's invite our Asian brothers and sisters to the table. Let's invite our Latinx community, brothers and sisters to the table. Let's invite the LGBT community to the table, because this affects us all. And when we're only focusing on one group, it's kind of like we're taking small strides, but collectively coming to the table and saying, you know what, we all have experienced this, so let us all stand up together and say, we're done with this. Let us all speak our truth. Let us all respect our truth. Because just because it wasn't your experience doesn't mean it's not valid. And I think we fail to validate each other. Everyone's experiences, they're valid. And so now that we have validated each other by sharing and saying, I hate that your community experienced that. How can we work together? Because at the end of the day, it all comes to the same point. It's inequity. We have to change that. And we can't change it by using one voice at a time. We have to change it by using the collective voice of everyone that is impacted by this inequity.
Thank you, Candace. And I think you also raised points about intersectionality, and that these are not separate issues, that immigrants and refugees may also be LGBTQ, or may also be persons living with disabilities, or may be in families with multiple racial, ethnic identities, and recognizing those shared pieces and those overlapping pieces is so key. Just want to say, I know that we've reached the hour. Claire just put a link for evaluation in the chat box. We so appreciate everybody joining us. We hope that you reach out to our emails or our Twitter accounts to continue this conversation, and ask additional questions, and let us know how we can collaborate with you and your organizations and institutions to advance this work. I want to thank the association for the National Association for having us here today, for Claire for helping, and for Candace for sharing so much of her wisdom and honor and expertise today. Thank you so much.
Thank you.
Thank you both so much. Like Jen said, I dropped the link to the evaluation, and I'll be following up with an email for everyone that registered. Everything will be posted to our website, and it'll be posted on Twitter when it's available. Thank you both so much. We really appreciate it.
Virtual hugs to everyone.
Yes, virtual hugs. If there isn't any other questions, we'll wrap up now. All right, it looks like everyone is slowly leaving. Thank you both, Jen and Candace. We really appreciate it. And I'll send you all the information after, once I have it all collaborated together. Thank you.